Okay, so as you can see from the title slide, my talk will be on managing regular school days and strategies for special days. I would like to begin by highlighting that the content I will provide heralds from the ISPAD position statement on type 1 diabetes in schools, and also the ISPAD Clinical Practice Consensus Guidelines 2018 chapter Management and Support of Children and Adolescents with Type 1 Diabetes in School. You can see this paper here, you saw the one before, and the references are at the end of the presentation. I really would encourage you to review these. Hopefully you'll find my talk both interesting and informative. However, I caution that the topic being discussed is much bigger than that I'm able to cover in the time allocated. So as you've likely or hopefully heard throughout the weekend's presentations and discussions, type 1 diabetes is quite a complex medical condition, to say the least, requiring skilled and intense management on both medical and psychosocial fronts. The need to both achieve and maintain blood glucose levels as near to, and I'll use the word normal, as possible at all times and for as long as possible in order to reduce the risk of both acute and chronic diabetes complications is very clear. So intensive insulin therapy, it's generally the recommended therapy for young people with type 1 diabetes. As you probably know, this is because it enables a greater degree of control. So when we consider all that this entails in the context of a school environment, one can well imagine the concern that may be felt. Try to imagine being the parent of a child with diabetes, having to be confident that school personnel will know how to deal with the multitude of issues relating to their child's diabetes care. In many settings, this can be compounded by issues such as lack of insulin and diabetes supplies, and maybe even challenges around transport. Many parents would feel insecure at leaving their child in the care of others. But then on the other hand, from a school or more so the teacher's point of view, supporting a child with type 1 diabetes may likely be daunting, especially if they have no prior type 1 diabetes related experience. The reality is that many school personnel are probably going to feel intimidated at the prospect of providing medical support that frankly they haven't been trained to undertake. Okay, so you don't need me to tell you that schooling in itself is of immense importance when considering the benefits and opportunities that education and social networks can bring. The reality is that students usually spend a significant proportion, often more than half of their waking hours at school, during which time they will be under the care and support of school personnel. There's also the time on top of this that students may spend participating in activities that occur after school, such as cricket or hockey, school sports days, excursions, and maybe even school camps. I think it's fair to say that the student with type 1 diabetes spends a considerable amount of time away from what is essentially the security of home and family supervision. With all this in mind, it is imperative that the quality of diabetes management during school hours is comparable to the student's usual diabetes management at home, so as to defer or prevent, where applicable, both acute and chronic diabetes related complications that I alluded to earlier. So what should the minimum of type 1 diabetes care be in schools? Well, the ISPAD position statement on type 1 diabetes in schools recognises that students living with type 1 diabetes face a wide variation in resources and circumstances, and such disparity can vary not only between countries, but also nationally and regionally, and as I'm sure you're aware, even by local area. So the position statement details that the absolute minimum level of type 1 diabetes care at schools in all countries should include the principles that I've got listed here, and I have no doubt that you would wholeheartedly agree with these. Okay, so to help frame this or put it into context, it's appropriate that we consider legal issues. The World Health Organization recognizes type 1 diabetes as a disability. Many countries have recognized type 1 diabetes as a disability in common law, and legal frameworks exist to protect children and adolescents with type 1 diabetes to ensure that students have an equal opportunity to participate in all aspects of school life. Schools in most countries are obliged by law to make reasonable adjustments to facilitate prescribed medical care to allow for students with type 1 diabetes to participate in education on the same basis as their peers. I understand from my colleagues in India that very recently a petition has been launched to declare type 1 diabetes as a disability in India. I have been informed that there was an excerpt in the Times of India, from memory, a popular newspaper in, I think it was January 2018, regarding type 1 diabetes as a disability for school exams. Naturally, it would be unhealthy for the relationship between a parent or parents, students where capable, and schools to solely be based on fear of legal ramifications. Regardless of legal ramifications, though, schools do have a duty of care for their students, and school personnel have a responsibility to take reasonable care to protect them from reasonably foreseeable harm, including out of target blood glucose levels. This is in addition to discrimination, bullying, and stigmatization, which can have a significant impact on self-esteem, motivation, and emotional health. So each student should have a written individualized diabetes management plan, which essentially is a formal document about the child's specific diabetes management requirements at school. This really is of great importance. The diabetes management plan should be provided by the parents, carers of the child with diabetes, and should be developed with input from yourselves, the diabetes healthcare team. Besides the doctor, this includes allied healthcare professionals as well. So this plan should be signed by a parent or parents, and where applicable, the student and the medical team. The diabetes management plan should detail in very clear language the medical instructions for school staff to follow on a day-to-day basis at school, considering aspects such as how to recognize low and high blood glucose levels, individualized protocols around related treatment, responsible supervision during recovery, where applicable, etc. Quite a long list. So the plan could also possibly detail what diabetes responsibilities can or cannot be undertaken by the student. So essentially, the diabetes management plan is the foundation for a cooperative relationship between the parent, school, medical team, and it should be reviewed and updated at least once a year. And certainly the parent can help drive this. Schools should have a clear understanding that the plan, though, is not to be altered by a third party under any circumstances without the consent and authorization of the parents and medical team, and school personnel should always act within their scope of practice according to the training and consent that they have received. So here is an example of a diabetes management plan. You can see that it's gone across 4 pages, and here is another one, again gone across a few pages. So it goes without saying that adequate training and education, if it's not received, school personnel will have difficulty understanding and applying the correct principles of diabetes management, and any ongoing lack of knowledge and misperceptions will undermine the core objectives of achieving optimal blood glucose control. So parents of a child with diabetes entering or starting a new school for the first time should inform the school principal or the school administration about their child's condition, and together they should agree on a strategy to inform and educate teachers and other relevant school personnel. Parents are generally the first to deliver this information, but you, the child's diabetes healthcare team, may also participate in this process. I understand from my colleagues in India, the reality is that it's often doctors who provide most of the training. I really want to flag, though, that training should be provided by personnel that have the appropriate understanding of the student's individual needs and skill sets. A parent might feel confident to do this themselves with support from local team. You probably will find that many third parties may provide generic type 1 diabetes education, but they bear no responsibility for clinical outcomes. Really, such persons shouldn't provide any medical advice on any aspects of the medical management of the child with type 1 diabetes. Any training must involve the informed parental consent, which serves as part of the process to enable a parent to authorize school personnel to deliver medical care to the child on their behalf. I've always found that as a healthcare professional, first, it's nice to get out and about away from regular work settings, and also that visits and contact with the school are almost always welcomed. I'd also imagine that such input would be extremely encouraging to parents and children. So the delivery of information and education about diabetes to school personnel, it can be achieved in a variety of ways using a variety of formats and media. Usual approaches involve face-to-face education delivered by the parents or yourselves, and use of web-based education tools and printed materials, either used alone or together. While I've often found that many people know of someone with type 1 diabetes and have some insight into the condition, I've also found that it's often best to start from the very beginning, going on the basis that absolutely no one knows anything about it. There's lots of misinformation out there. So which school personnel should receive education? Well, almost everyone. Well, education is mainly aimed at nurses, and I say where available, as the reality being nowadays, most schools don't have a nurse. In addition to teachers, physical educators, and other teaching assistants directly supporting the child with diabetes. But training and education of other school professionals is also recommended. The provision of information to fellow students and their parents can be helpful and will facilitate inclusion and avoid potential discrimination. But I say this, I understand in India, having type 1 diabetes can be considered a bit of a taboo. I think it is pertinent to flag the value of fellow students, though, and certainly have the discussion. While peer relationships may influence diabetes outcomes, certainly chances are that the student with diabetes will continue to maintain friendships as they grow, potentially developing a larger set of people who can help keep an eye on and report concerns to teachers relating to the person with diabetes. Finally, the students with diabetes themselves, they're responsible for bringing their diabetes equipment to school and carrying fast-acting carbohydrates. While it's important to highlight that there's no specific age at which children with type 1 diabetes should be expected to take on full responsibility of their diabetes self-management. They may, for example, measure blood glucose levels, make decisions and inject insulin, provided there is adult supervision. Certainly encouragement and support with diabetes self-management tasks are required throughout the school years. Schools should have a safe place to store medication and supplies, but I appreciate this may be difficult. Not everywhere has access to a fridge, perhaps use of a clay pot. Do also remember the advertised periods of time that insulin can stay outside of fridge environments. Teachers and school personnel have to be aware that students should have access to their devices and medication whenever needed. And all children with diabetes should be provided with a safe place and adequate privacy to perform blood glucose testing, and where applicable, insulin administration should they request or desire it. While it's expected for all children with type 1 diabetes to have their insulin administration delivered or at least supervised by a member of the school personnel, this is not always realistically possible for many places. The school personnel may not agree to take on the responsibility of administration, as it's likely to be outside of their scope of practice. School staff must therefore volunteer to take on this role and cannot be nominated or designated to do so. In some countries, I even understand it's forbidden for a non-healthcare professional to administer medications such as insulin or glucagon. It would be worth you finding out whether this is the case in India. Families, together with the diabetes healthcare team, they may realistically need to make specific individualized arrangements with the school. If the school or school personnel cannot assume responsibility for performing or overseeing insulin administration, parents or a designated guardian may have to go to school to do it themselves, and I understand this is often the case in India. Naturally, the privacy of the students and confidentiality issues relating to the student with type 1 diabetes must be respected and discussed with the student and parent. Okay, so on to relationships now. I mean, underpinning all of what I've detailed prior should be a cooperative, supportive and respectful relationship between the three key stakeholders, parent to parents and the student, and they're capable of greater independence and self-care, school personnel, whoever that may be, and finally the medical team. My experience has been that almost always all of these stakeholders are committed to making things work. And it is imperative that there is ongoing effective communication process between the parent or parents, student where capable, and school personnel. And to be productive, this communication should be respectful, transparent, and easily accessible by all. Schools really should be supported by the parent or parents and the student's medical team to establish processes to address any issues and to provide appropriate information regarding the use and handling of appropriate applicable diabetes equipment. My experience has been that problems realistically are more likely to occur when the usual routine that everyone has been accustomed to changes, such as when a teacher is on leave and is replaced by an unknown substitute teacher. So measures need to be put in place for such instances. While school personnel always should feel that they're able to contact the parent or parents, they should also consider the student's medical team as an accessible resource to contact with parental permission. A member of the medical team should agree to and be identified as the source of contact for each student with type 1 diabetes. Applicable contact details should be provided accordingly. My experience has shown that it's often best to have numbers detailed for more than one person. Certainly in an emergency, the school will need to get hold of someone quickly. Naturally, emergency assistance should be sought where applicable, such as if the child is unable to eat or drink or treat any hypoglycemia. Okay, so now I'm going to go on to the second component of my presentation, focusing on some aspects that you, as part of the medical team, will likely be expected to advise on and address throughout the school years. I'll be somewhat brief though, so as to incorporate as many concepts as I can in the remaining time. Okay, so on to insulin. So I really just wanted to highlight that insulin requirements during school years will very likely change. I'm sure that you know this already, but when considering approaches to insulin therapy, in summary, there are many. The type of insulin regimen really should be tailored to the needs, ability and wishes of the child with diabetes and their parents. And again, such facets may again change over time when considering the child's physical and psychological maturation and a multitude of other factors. So as alluded to earlier, insulin administration at a school must be delivered safely for every child with type 1 diabetes. Preferably a member of the school should have the responsibility to assist with insulin administration, or at the very least to supervise the child undertaking this. School personnel responsible for supporting students with type 1 diabetes should ideally also be trained to make insulin dose adjustments where applicable at school. Things such as bolus calculation apps, bolus calculators on blood glucose meters, etc., insulin pumps, they can certainly help facilitate this. So the optimal timing for a pre-meal bolus can be difficult to apply at school, where some meals are unpredictable, both in terms of timing and expected content of food, and thus recommendations for meal insulin dose administration in schools need to be individualized. As always, hypoglycemia that occurs immediately before a meal should be treated first, with the subsequent mealtime insulin dose being calculated from the carbohydrate content of the food to be consumed. Specific instructions regarding insulin administration and insulin dose adjustments at school should be incorporated into the student's diabetes management plan. So in situations where it's either not possible or desirable to administer insulin boluses during the school day, adopting less intensive insulin administration regimens, and a twice daily injection regimen using a combination of intermediate acting insulin and regular soluble insulin may avoid the necessity of doing injections at school. But yeah, this is not ideal. Blood glucose monitoring, this is central to achieving optimal diabetes management and really must be familiar to school personnel. I've generally found that school personnel like blood glucose monitoring since it provides them with an indication around the child's status, and as part of this possible reassurance, a blood glucose check prior to insulin administration is almost always required, being safe and appropriate practice. Capillary blood glucose values should be checked by finger stick testing using a portable blood glucose meter. The general minimum frequency of self blood glucose monitoring testing during the school day is before each meal, as well as before and after physical activity. This is in addition to before a school test or exam, since both high and low blood glucose may adversely affect exam performance. More on this later. But in summary, blood glucose testing can help provide reassurance, and school personnel really should be encouraged or allowed to undertake extra tests if deemed warranted, and that should be on the management plan. There's also continuous or intermittent scan glucose monitoring to consider, but I'm not going to focus on them in this presentation. So you don't need me to tell you about the importance of young people having a healthy, balanced diet for optimum growth and development. I'll be rather brief here, considering it's my understanding that other sessions relating to nutrition have been planned. However, in this context, access to food in schools is an integral part of enabling children to grow normally, exercise and balance their insulin and food intake. Meals eaten in school may actually make up a large proportion of a child's daily nutritional intake. And while access to food in school varies, food in school for some may include breakfast clubs, snack times, after school clubs. So for a child or young person with diabetes, food in school requires management according to their treatment regimen. Excuse me. So children using either multiple daily injection or pump therapy will need to count carbohydrates and calculate insulin dosages according to their blood glucose level, the amount and type of carbohydrate, meal composition, activity both before and after meals, and previous insulin bolus. Insulin should ideally be delivered before eating for children that are on twice daily insulin regimens, so as to prevent hyperglycemia and match the action profile of insulin injected at the beginning of the school day. They will require both a midday meal and snacks. So the calculation of the carbohydrate content of school meals requires information about foods available in the school, nutritional content of the food served, and portion sizes provided. On occasion, food may need to be sent to school with the child, and I understand that in India, few schools provide food, so this is more likely to be the case. Use of food pictures, photographs may also assist school personnel to estimate the carbohydrate content of the meal for the purpose of insulin dosing, and such images can be provided to them by the families or you as the medical team. The provision of a prepared packed lunch made by the family or carer does offer the advantage of allowing information about the carbohydrate content in each food serving to be determined for the child and school personnel. And where the child has a coexisting medical condition, the celiac disease, which requires additional dietary adjustments, these should be assessed and included in the prior mentioned and individually agreed diabetes management plan. Okay, so I think it's important to flag that physical activity in children can differ considerably depending on age. Differences are generally noted regarding the aim of physical activity when considering fun versus performance. Younger children often take physical activity in bursts as part of typical play, whereas children that are older usually conduct planned activities. The risk of hyperglycemia is a major barrier to physical activity, which really indicates the importance of providing structured education and support from you as part of the medical team. So for physical activity lasting less than 30 minutes, additional carbohydrate is only needed if the activity is of high intensity and or if the blood glucose values before the activity onset have been clearly showing a declining value. When physical activity is regularly being repeated in short bursts or is particularly intense, such as sports days, additional measures are required. Carbohydrate supplementation is needed during exercise lasting longer than 30 minutes and will be needed in between any short bouts of exercise and after the exercise session is finished to prevent late hyperglycemia. Besides a plan regarding carbohydrate supplementation, a plan is also needed regarding insulin dose reductions, which may involve bolus dose reductions before physical activity, bolus dose reduction after exercise due to insulin sensitivity post-exercise, and or basal insulin dose reduction during and after exercise, really aiming at reducing the risk of hyperglycemia. It is important to clarify though that adjustments to carbohydrate delivery and to insulin dose are intended to balance each other. If insulin dose is not required, then a larger amount of carbohydrate is required and vice versa. So at all times, planning is essential before the activity, together with advice regarding what to do if hyperglycemia or hyperglycemia, so hypo or hyperglycemia occurs. So carbohydrate is the preferred option before planned exercise, and that the type of amount should be tailored to specific needs. I've often found carbohydrate in the form of fruit is often a good option. It provides vitamins, minerals, and fibers as well. So the children, and where applicable, their teacher or trainer should also have in their possession at all times rapid-acting carbohydrates to manage hyperglycemia should it occur during the exercise session. You wouldn't want them to have to travel to the other side of the school to get treatment. Okay, so I just wanted to spend a minute or so talking about emotional health, an aspect that can be overlooked when compared to the medical management of type 1 diabetes. It is important that all school personnel understand the emotional burden experienced by families when given a diagnosis of an incurable disease such as type 1 diabetes that will relentlessly impact upon the students, siblings, current family relationships, parental working lives, in some cases even understanding their marriage prospects. I have been speaking to your course leaders about this prior. So here and now, a diagnosis of type 1 diabetes may cause students to feel different from their peers and put them at risk of being stigmatized, resulting in a higher risk of them experiencing anxiety and depression. And as we know, some children can be particularly cruel with their comments. Families that have been traumatized may feel helpless and maybe disempowered, and yet they still have a duty to advocate for their child. When considering psychological adjustments, studies report variable rates of psychological problems such as depression and eating disorders in young people with type 1 diabetes, with some indicating rates similar to the general population and others indicating much higher rates. Disordered eating and behaviours to control weight, into admission, strict dieting, are also common in young people with diabetes. Depression and eating disorders are associated with more frequent episodes of diabetes ketoacidosis, earlier onset of complications, and poorer glycemic control, treatment adherence, and quality of life. Certainly since teachers and other school personnel often observe these youths interacting with their peers, if properly trained, they can be well positioned to recognise possible problems in these domains and to refer for more complete psychological assessment and treatment in a timely manner. Exams and stress, I might just actually leave this as looking at the time. Okay, so special days, it's not uncommon for people for special events to arise from time to time, necessitating possible deviation from the agreed diabetes management plan. It is of great importance that parents and subsequently yourselves as part of the medical team communicate regularly and that knowledge is obtained relating to the special day, I know the birthday party or what have you, as far in advance as possible. This is so as to allow temporary amendments to that agreed diabetes management plan pending the deviation required. Thank you. And sorry, here are the references that we talked about before. Thank you.